Deputy Director of Nursing for Cancer, and I work across Mid and South Essex NHS Foundation Trust. So we cover 3 large hospitals.
Hi, my name is Kelly Buckingham and I am the colorectal patient stratified follow-up CNS here at Basildon Hospital, looking after patients that have had curative surgery for their colorectal cancer.
We are one of the largest trusts within the country now since we've merged, and we diagnose over 10,000 new cases of cancer each year, so we see a large number of people affected by cancer. So beetroot as an IT platform was originally envisaged to be used for personalised stratified follow-up, so to follow up those patients who had completed treatment and needed monitoring. And we reached out a number of years ago to Beetroot, to the company, to support us with remote monitoring of patients, so to ensure that they are followed up effectively and safely, and ensure that we give a good service to them. We wanted to improve our service, and we've been really fortunate working with Beetroot because they've enabled us to set up a really good remote monitoring system. And that means that it's really beneficial to patients, but also beneficial to our service and our clinicians. And the reason being is that it can mean that patients are not regularly having to come up to hospital if they don't need to. So it means that we can remotely monitor them. We can also send questionnaires to them, which has been really great service. So we can do quality of life assessment, holistic needs assessments. And that means that we can get information really speedily from patients, and also if their results, we can monitor them, and if there's a problem or a concern, that highlights to the nurse specialist, and it means that we can rapidly access the patient and contact them and bring them into clinic. So we're actually seeing them when we need to see them. The work that we've done with Beetroot is that we've extended that to include active surveillance. So patients with prostate cancer who need active surveillance prior to commencing treatment, or just that may not ever reach treatment, we're able to use the IT platform to monitor those. And something that we're also very keen to expand on is those with precancerous lumps or precancerous cysts, for example pancreatic cysts. We're very keen to use Beetroot to follow those up that may need to have scans or blood tests to monitor to see if they will turn into cancer in the future. Because that takes up a huge amount of resource and surveillance needs, and actually it's hugely beneficial for patients and for our capacity to have those remotely followed up. So it's not just those with cancer that have completed treatment, it can actually incorporate many aspects of the patient pathway.
Previous to that, these patients would be mixed in with our palliative patient phone calls or clinic appointments, as well as high-risk cancers. So they would all be mixed in either with a face-to-face clinic or telephone clinics. And now, utilising Beetroot, we've been able to separate these patient groups to streamline our curative pathway alongside our high-risk pathway and metastatic disease patients.
Beetroot have been really helpful in setting up with a number of tumour sites, which has meant that it's been really flexible. We've been able to adapt it to the needs of the service and the needs of the patient. So we've built the service around them with the use of Beetroot as an IT platform.
So our Beetroot system will monitor our CEA results, so our cancer marker results. Every day I come in, turn on the computer, check for my alerts. And it's one of the things that I inform my patients, that no news predominantly is good news. If they don't hear from me between having their blood test taken and the date that they're roughly due to hear from me, either via a telephone call or a results letter, it's because their CEA markers are within normal range. There's been a few occasions where those CEAs have been elevated. I've been able to contact the patient sometimes 2 weeks before they were due to have their review, and it's 2 weeks of getting the ball rolling and getting them investigated, spoken to, sometimes even on MDT before their appointment date as such.
I think it's made a huge impact on our waiting list. We know that we are having to follow up thousands of people affected by cancer because we're fortunate that people live a lot longer with cancer now. So actually people needing to be followed up, the numbers have increased hugely. And so what that means is with having Beetroot, we can have a number of patients on that remote monitoring that don't need to come up to see oncologists. and that means that we have those that do need to see the oncologist have those appointments readily available. So we have thousands of patients now being monitored on our beetroot system, which means that enable us to have many more appointments for those with complex problems or new diagnosis that need to be seen urgently. Whereas those that are doing well and are well at home, we can monitor them, and then they're not having to come up to hospital for the results. We can send them a letter or contact them remotely.
So once we started sending out questionnaires, it was the uptake to begin with was slow because it was such a change for anybody's follow-up. Even being over the telephone appointments, it can be quite daunting for patients because they think, oh, we've had a cancer, we should be seeing people face to face. So it has been a sticky point, but we've got there. And sending out our proms to patients. One patient in particular does come to mind. Whenever I would call him, he would be very much, yes, I'm fine, not a problem. And then one day he received his proms. It was very early on in his follow-up still, and he was honest in his proms responses. And he felt that because he wasn't actually having to say the words out loud, it prompted him to be able to say how he was truly feeling. And we were able to help him with some counselling from our Macmillan counsellors here at the hospital, and also our Active for Life programme, exercise rehab programme, which he found to be greatly beneficial. And without that proms questionnaire, he probably would still be feeling as he was, very, very low and unable to express those emotions effectively.
So our service overall at MSE, we've seen a huge impact with using beetroot cancer, and where previously patients were potentially being monitored on a database or an Excel spreadsheet, we had real concerns over patient safety, and we wanted to improve that, but not only to ensure that patients were being safely followed up, but also to ensure that they had quality metrics and that we were assessing their quality of needs, assessing their holistic needs, and really driving improvements with our service to ensure that they had swift access when there were results that were highlighted that needed a clinician input. And it also meant that efficiencies were there for the patient. They didn't need to be regularly coming up to hospital. And this has shown that we can follow up a huge number of patients in a really safe manner that actually meets the needs of the patient. It then releases time for the clinician to see patients as needed. And I think this model is just growing across MSE. We're seeing all tumour sites very keen to use the beetroot system to really improve their service. And also, as I said, wanting to expand that in not just patients that have finished treatment, but those that need actively monitoring prior to treatment or with precancerous cysts or symptoms. And so I think regionally we've been showcasing how excellent this system is, and actually I think it could be used regionally to really drive improvements across the board in cancer.
With regards to streamlining our service as a whole, we are now utilising beetroot proms to monitor our polyp cancers that we look after here at Basildon. They've had a curative polypectomy. So no surgery to remove their polyp cancer, and it's been taken out via colonoscopy. And this way we are able to utilise the system to look after them, and in the same way that we would do all of our other colorectal patients. But we are also now utilising the system for our neuroendocrine tumours that are found in the bowel, but also our appendiceal neoplasms that are follow a slightly different follow-up, but we've now got a pathway available for us to use on beetroot for them as well.
I think for us, we do use Somerset as a registry. So when patients are newly diagnosed, they're put onto our Somerset as a register, and we track the patients through Somerset. We found that we were quite restricted with Somerset, that it was something that not all clinicians could access, that it had limited information, and that the system was very rigid. And actually what we wanted was a system that we could actually develop and we could really tailor to the needs not only of the service but the needs of the patient. And that's been hugely beneficial, that we can add on those extra parts with Beetroot of contacting the patient, sending them messages, sending them questionnaires to complete that then comes directly back into our system. And as well as that, with Beetroot we've been able to link in with our other areas that are vitally important, such as endoscopy, as radiology, as pathology, to ensure that all the results are there to safely monitor the patient. So those other systems have been more crucial to us, and having a system that we can develop with the company to meet the needs of the service has been hugely beneficial.
So my name's Susan Calpathwaite. I'm one of the IBD nurses at Southend Hospital. So we started using Beetroot about 3 to 4 years ago. It was introduced by one of our consultants that got us in touch with it, purely for the basis of finding out why and when a patient contacts us, we find it the best way to put all communication in one area. So patients sometimes email us or telephone us, and we would put their communication on Beetroot and our reply would go on there as well. So we're using it as a communication tool between the team.
My name is Michelle Stallybras and I am the lead administrator for PSFU and beetroot cancer across the MSE at Mid and South Essex hospitals. So I was asked to come on board with the Beetroot project quite early on in terms of its actual setup and build, and I was instrumental in setting up the clinical governance guidelines and looking at how the system was going to work best for the urology department as a whole. So we were looking at setting it up to deliver good outcomes for patients if they were experiencing problems getting appointments in regular clinics. As I said, we've had a lot of problems with overbooking and staff having to work extra time, so it's not unusual for some of our staff to work overtime, to work at weekends and to work on bank holidays to fit patients in. So the Beetroot system was really instrumental in taking some of those patients away and lessening that workload. So we were looking across the board at different clinic codes with different nurses and different consultants across the urology department, specifically just at Southend at first, to look to see what criteria we could set in place to take away some of those patients from those overburdened clinics and move them onto a patient stratified system such as beetroot cancer. And that was what we were doing in the early days.
The findings of other things we use it for blood testing. When someone starts on a new drug or a new diagnosis, it all goes on there. But as any system is, it's only as good as the person that inputs that information. So we do find sometimes it is time consuming, but once it's on there, it works really well for the team. So it is, like I say, a big communication tool, but we've used 3-4 years now, and it's working really well. So if I was to put some information on there, and then another nurse would look at it later on, it would come up on the system quite nicely, and we'd see everything from myself and a patient. And other consultants use it as well, but they don't actually input onto Beetroot. We do it for them because they don't like to use that technology, unfortunately.
So with regards to monitoring of patients, we've set up the system so that we can look at specific blood tests, and for urology patients that's something called a PSA, and a patient will go along and have a PSA done at set intervals along their pathway depending on how far away from treatment they are. The blood results will come back into the Beetroot system, and we can tailor-make alerts that are, like I say, tailor-made to each patient, and we can set the parameters as to when those alerts are going to come onto the system. Once the patient has alerted, then the administrator is fully trained to be able to know what to do with that particular alert. They can review it and they can outcome it. We have specific lines of communication in place so that the patient can be fast-tracked back into the urology system and see a clinical nurse specialist should they need to. But we also have the ability for patients to just be left alone and live life beyond their treatment for prostate cancer, and they can call us if they need to, rather than us calling them on a regular basis.
So from a safety point of view, we use Beetroot purely when we start them on a new drug. So as we use a lot of high cost drugs, they're biologics or immunosuppressants, so they have to be very monitored very closely with blood tests regularly. So say I put someone on azathioprine, they'd need blood tests done 3, 6, 9 and 12 weeks. So it's that role that we use it for quite good, and it works very well to make sure a patient is having their blood tests done. We usually prescribe them a certain amount, and if they don't have the blood test performed, then the drug won't get issued to them. So for a patient's point of view, it's a safety net for them to get more medications on board. And for us, no blood test means no drugs. So again, it's a safety thing from our point of view. And if we saw something trending out, like a liver function test or a UNE, we would spot it quite quickly if we looked at those blood tests. Unfortunately, as an IBD team at Southend, we don't have admin support at the moment, so we are the admin team. So that's why it's important for us to use that communication tool. As a trio, we do it very well.
In terms of the actual use of the system, then the administrators are the principal users, and I'm just talking specifically about urology there. We are lucky enough to have administrators in our department. I know that there are some departments that aren't quite so lucky with that, but the administrators are fully trained to be able to recognise what they should do with the particular alerts. Where the clinicians come in is setting those parameters in the first place. So it's really important to have that hierarchy of staff where you've got somebody who's setting those parameters, and that's a clinical decision, and then you have an administrator carrying out those decisions and monitoring the alerts as they come in.
Initially, we did have an admin team working 3 or 4 years ago, and she was excellent. She'd put everything on there.
And a lot of the tumour sites that we're getting on board are actually using the PROMs more and more. So in terms of the communication with the patient, we find that it's a really good and effective tool. And lots of people these days use mobile phones to communicate. And so the ability to be able to send a questionnaire really quickly and really easily to a patient's mobile phone, they can fill it out quickly and easily, send it back to us, and that can be actioned almost immediately in real time. But it also gives that patient that link. We were really keen to make sure that our patients didn't feel like as soon as they moved over onto remote follow-up that they were kind of cast out into the community and they didn't have that link back to us. And the HNAs and the questionnaires have reassured patients that there is that link, and if they do have any issues or worries or concerns, they can contact us really, really easily. So the active surveillance arm of the development of beetroot is really in the early stages, and what we're looking to achieve is really along the same lines. We have a huge number of patients who are currently in our clinics who have some degree of prostate cancer, but it doesn't actually need any treatment right now, so they're kind of on a watch and wait policy. But as you can imagine, the more patients we see at disciplinary team meetings and in clinic settings and who are referred from GP practices, that cohort of patients just becomes larger and larger and larger, and it gets more and more difficult to monitor and maintain any progression from those patients. So looking at that particular cohort of patients, we can move them onto the beetroot system and put some monitoring processes in place so that we can keep track of where they are within their pathway.
My name's Katie Lowe. I'm the Associate Director of Nursing at Mid and South Essex Hospitals. For us, it's the adaptability of beetroot that is the thing that serves us really well. We know that we can use it in various different ways against different tumour groups. Obviously, the tumour groups are very, very different. Patient cohort is very, very different. The disease progression is very different. Everything acts in a way that you can't really predict to be able to build a model that would move from one tumour site to the next. So the beauty of beetroot is that we're able to kind of use it in a way that facilitates the services as best as possible, but it is also adaptable so that we can move away and think, actually, that's not quite the right way that we need to be looking at it. Our nurses lead that process with the clinicians, and so we can step back, look at the process, come to you guys, have a conversation and say, actually, we need to turn beetroot in this direction for us to capture this cohort, for us to be able to bring about this effective change. And by doing that, it just means that everything is really bespoke, and that isn't just to the tumour site. We can really bespoke it to each individual patient, which with many digital services that we have in the NHS isn't something that is readily available. So that's why it's so unique and why we want to keep a hold of it and drive it into as many tumour sites as possible. So at the moment we're using it for stratified follow-up, so personal stratified follow-up in a number of different tumour sites. That's allowing us to follow the process of patients through, make sure that they're clinically monitored in a remote way with easy access back into services should they need. It's also a way for the clinicians to monitor remotely those patients that they would generally be not too concerned about, but concerned enough that we need to look at them clinically through a clinical lens. It gives us the opportunity to do that. Alongside that, we need to also remember that patients don't just come with a clinical diagnosis, they also have thoughts, feelings, they have a personality. We need to be looking after that as well. And so with the beauty of beetroot, we're able to look at the holistic needs of those patients and detail the holistic needs assessments. That that style of working with the patients is allowing us to use patient prompts, so we're able to send out questionnaires, again very bespoke to the tumour site, to the patient group that we're looking after, to make sure that we are getting it right and we are looking at what needs to occur for that patient along that part of their journey and their pathway. For us, from a nursing perspective, we're very excited to use beetroot in nurse-led follow-ups. At the moment, stratified follow-up is a nurse-led service, but it is clinically led. If we can move beetroot across onto the nurse-led follow-up platform, it will mean that we can run many more patients through our nurse-led services, keeping a hold of that cohort and understanding what the activity looks like. Once we understand what the activity looks like, what those patient groups need, we're able then to expand the workforce into those areas so that we can be really responsive to the patient group instead of being reactive, which is something that the NHS does sit upon quite regularly. So it will be a really new way of working, a new way of thinking, but certainly an area that needs to be expanded into and one that we're really looking into doing at MSE. I think for the nursing staff, certainly the system is very user-friendly and very helpful. The fact that it can be monitored and run by administration takes away the administration part of beetroot, so the nurses can concentrate purely on the clinical side. An example of that would be a patient that, let's say, has completed a H&A, holistic needs assessment, and wishes to have a clinical callback. They're able to tick a box on that form to say, I would like a clinical callback. That comes through to us as a red alert. That then is forwarded on to the CNS directly. They have a period of time, which the CNS denotes that period of time when we set the system up, as to how and when they will return that call back to that patient. Which means not only are we, again being bespoke, we're looking after the patient need, but it gives that clinical duty back to the CNS and has taken away that initial triaging process that the admin team can do for us. Another example of that is the H&A coming through again and being completed and it all being green. So essentially the patient is happy, ticking along at home, really comfortable and confident in the service that they're being monitored by. That doesn't need to come to the clinicians, it doesn't need to come to the clinical nurse specialist, so it stays with the admin, it's processed in a way that it sits on the records, and then we're able to pick it up should we need to in regards to running processes, or if we need to pull a report to show us the amount of patients that are there.
So beetroot has really expanded since I first came on board back sort of 5 or 6 years ago. So we're now looking at introducing lots of different tumour sites to use in the beetroot cancer platform, and that's been really interesting, and it's really opened up to me how the system can be used really flexibly to carry out lots and lots of different requirements for each specific tumour site. And it's only been quite recently that we've had all of this different interest from different tumour sites that we can really see how flexible the system can become, and it can become really tailor-made to the cohort of patients that tumour site needs to track.
We think that it is a service that isn't necessarily being used for follow-up elsewhere. Other follow-up services are quite rigid in their structure. They're usually an add-on, a bolt-on to another digital service, whereas beetroot for us is standalone, it's completely flexible. We can build into it what we need, and as we've already spoken about, we're using it for stratified follow-up at the moment. We've looked at using it for rapid diagnostics. We are using it for our holistic needs assessment. We're now doing follow-up with our radiotherapy patients, and that's via the route of patient proms. So there's lots of different ways in which you can use it, and as I've already alluded to with the nursing aspect for clinical nurse specialists and mobilising that workforce, it will be for us using it in those nurse-led follow-ups, which will be the key to unlocking a lot of oncology capacity, whereas previously we didn't have that at our fingertips, and now we do. So it will be building beetroot into that process to support us in hopefully being one of the first trusts across the region to run an operational cancer nursing workforce.